painful periods are not normal.
No. The most common symptoms of endometriosis are around pain, painful period, painful urination, painful sex with deep penetration, painful bowel movement, back pain, bloating. 90% of patients with endometriosis have some form of leaky gut, IBS, irritable bowel syndrome.
Can endometriosis spread?
50% of counties in this country don't have an OBGYN.
What are the criteria they should be looking for a surgeon that will help their endometriosis?
The gold standard treatment for endometriosis is...
Hi guys, it's Mary Alice Haney and Dr. Thaïs Aliabadi, and we have some amazing news to share with you.
You've been asking and we've been listening because nothing matters more to us than your feedback. We know we had to make this happen. OV now comes in a brand new flavor, tropical.
It's the same science-backed hormonal and metabolic support that you know and love, now with a refreshing tropical taste that you actually look forward to taking every single day.
We're so excited for you to try it, and we can't wait to hear what you think. So let us know. Go to ovii.com or on Instagram at @ovhealth.
March is Endometriosis Awareness Month, a time to bring attention to a condition that affects 10 to 20% of women, yet is still widely misunderstood, and often it takes years to get to a diagnosis. I'm Dr. Thaïs Aliabadi, and in this episode, I want to take a deeper dive into what endometriosis really is, beyond the headlines and beyond the misconception. We'll talk about why so many patients are dismissed or misdiagnosed, what symptoms you should never ignore, and how endometriosis can impact everything from your daily life to fertility and long-term health. I'll also walk you through current approaches to diagnosis and treatment and what I believe needs to change in the way we care for patients with this condition. Whether you've been diagnosed, suspect you might have endometriosis, or just want to better understand your body, this conversation is here to inform, validate, and empower you. Let's get into it.
All right, let's start with the basics. What is endometriosis?
Good question. So endometriosis is a systemic inflammatory neuroendocrine disorder. So it's not about just painful periods. It's a condition that affects it from our head to our toe. So it's very important to address the patient as a whole and not just based on just one symptom like painful period. Endometriosis affects 10% of women based on what the literature shows. However, I think that number is north of 20% because majority of these patients are never diagnosed. It takes doctors 9 to 11 years in this country to diagnose endometriosis. Majority of patients go undiagnosed. Average age being 32, because at this age, either patients are trying to get pregnant and they can get pregnant, or they bounce from doctor to doctor for years and years until someone validates their symptoms and diagnoses them with endometriosis. Endometriosis, unfortunately, does not have a blood test or an ultrasound for now to help us diagnose. However, for me, I've done this for many, many years. In order to diagnose endometriosis, you do not need a fancy ultrasound, an MRI, a blood test. All you need to do is listen to your patient, because that's all I do. Now, I do a pelvic ultrasound on everyone, but you can't diagnose endometriosis on ultrasound in majority of patients unless they have a finding in their ovary. So just by listening to a patient, you can diagnose endometriosis. For doctors who are not experienced and haven't seen as many endometriosis patients, if they only listen and they know what to look for, then they'll get to an 85-90% accuracy for diagnosing endometriosis.
So what are the symptoms, the main symptoms of endometriosis?
If you think of endometriosis, think of pain, right? If you have a young patient who's constantly bouncing in and out of emergency room, doctor's office, urgent care, with pelvic pain, whether it's painful periods, pain with sex, pain with orgasm, recurrent bladder infections every single month. And I say quote unquote bladder infections because these are not real bladder infections. And when you send the urine culture, it comes back negative. But these patients have the symptoms of bladder infections like urgency, painful urination, pain with bowel movement, chronic pelvic pain, sciatic pain, bladder pain. So it goes around pain, pain, pain. So that I would say pain is the most common sign. These patients usually complain of bloating. They get diagnosed with irritable bowel syndrome, SIBO or small intestinal bacterial overgrowth. A lot of them end up having colonoscopies, endoscopies because the GYNs are not diagnosing. So they bounce to a gastroenterologist because they also have these bloating issues, even when they're not on their period. So they will tell you that when they eat, they get bloated, right? Even when they're not on their period. And that we see commonly with endometriosis patients. So I would say pain is the main. So I always tell patients, if you show up to your doctor's office and you sit on that exam table and you complain of pain, that's the first red flag. If you end up in the emergency room, urgent care, student health, when you're on your period, that's the second sign. If you change your life around your period, if you change your social calendar, if you plan your trips around your period because they're so painful, if they really bother you and they disrupt your life, then that's endometriosis until proven otherwise. So, but unfortunately, there are millions of girls having these symptoms, but they're told by their doctors, time over that it's normal, that you're probably dramatic, that you're probably anxious. Is this a stressful month? Maybe it's because you have your finals and you're in so much pain. None of it is true. So it's so important, not to dismiss these patients. But the problem is parents dismiss their daughters. The first thing they tell their daughter, oh, I had painful periods, or your grandma had painful periods. But painful periods are not normal. It wasn't normal for you. It wasn't normal for the grandmother. And it's definitely not normal for your daughter. And because it's one of the top causes of infertility, it is crucial to diagnose these patients at an early age. They're teenagers with debilitating pain. I'm doing a laparoscopy in a 15-and-a-half-year-old next week. She's coming from Northern California. Her egg reserve is very low for her age, and she has pain with her periods, and she's not responding to birth control. So you cannot dismiss these patients. If it's disrupting their life, then you have to address it.
Can you talk about the stages of endometriosis and how stages don't mean pain?
I'm so proud of you, Mary Alice.
Dr. Mary Alice Haney.
Dr. Haney. So you're right. There are 4 stages of endometriosis, from minimum to mild to moderate to severe. And the degree of pain that patients experience has nothing to do with the stage. So you can't say, oh, so-and-so's pain is minimal, so you're stage 1. So-and-so ends up in the emergency room, she must be stage 4. You have stage 1 patients ending up in emergency room, and you have stage 4 patients who have moderate pain. So staging is surgical staging. It depends on the surgeon. That's why you need an experienced surgeon to stage it. Again, I think you need to do at least 100 cases minimum, before you can even be able to stage these.
So what causes endometriosis?
So we don't understand a lot about endometriosis because endometriosis, to plain and simple, to make it very easy to understand, is when cells similar to the lining of or tissue similar to the lining of the uterus is found outside of the uterus, around the tubes, ovaries, in the pelvic area, on the bladder, on the bowel. You can even find it in the upper abdomen, on the diaphragm. So these are ectopic implants that function like endometrial tissue, but outside of the uterus. There's some hypothesis that says when we have our period once a month, so every month our ovaries secrete hormones to get the lining of the uterus ready for pregnancy. When we don't get pregnant, the lining comes out, breaks down and comes out. There's a hypothesis that says we have this retrograde menstruation, which means some of the endometrial cells that get released during the menstrual cycle, they go backwards into the tubes from the uterine cavity, and they come out of the tube and they implant inside the pelvis on the bowel, bladder, or pelvic sidewalls. Generally speaking, with a normal immune system, when this happens, our immune system attacks these cells, clears it up, and cleans it, so nothing happens. But endometriosis patients, their immune system does the opposite. It basically, what happens in these patients, these implants get stuck to the side, to the pelvic sidewall, to different organs in the pelvis or in the upper abdomen. And each of these implants start an inflammatory process, and they start expressing the aromatase enzyme, which starts producing estrogen. Endometriosis implants grow with estrogen, and they tend to be progesterone resistant, but their growth slows down with progesterone, or their growth is suppressed with progesterone. The problem is, as they make their own aromatase, as they express their own aromatase, they make their own estrogen, so they become independent of the ovarian estrogen secretion, so they can survive. Eventually, they grow blood vessels, they grow nerves, and they start basically invading the tissue around them. And that's why they can cause an inflammatory process in the pelvis that, because it goes dismissed for months and months, years and years, this causes scarring in the pelvis, blockage of the tube. If you have endometrioma, growing inside the ovary can affect your egg reserve, your ovarian reserve, your egg quality, and eventually the scarring and inflammation, it can block your ureters that drain your kidneys. It can cause bowel adhesions. It can cause bowel obstructions. We had a podcast we did with a patient of mine who had a bowel resection because for 9 years, doctors told her she was fine and there's nothing wrong with her. Going back to these implants, every month more cells start adding to the growth of this endometriosis, this grouping of endometriosis implants, and they progress month after month, year after year. The problem is there's a central sensitization that happens. Basically, these implants, as they grow their own nerve fibers, they hijack our nervous system, and they crank up the volume in the spine and our brain to perceive these pain pathways in an exaggerated way. Meaning, if that one nerve fiber should be a 2 out of 10 pain, this central brain rewiring that happens over time with endometriosis makes the patient perceives the pain as 10 out of 10 pain. And that's why patients with stage 1 endometriosis end up in the ER, right? And when you do a laparoscopy, they might have 2 or 3 implants or 2 or 3 nodules, but one of those nodules is enough to put that patient in the emergency room.
But so can I ask you, because you hear a lot that painful sex is one of the symptoms. Why, with deep penetration? So what is happening? The penis is going in and it's hitting one of those nerves?
Yes. So when you have, when I do an ultrasound, if you go behind the cervix and push in that area, your patient jumps. That's the most common place for these endometriosis implants, is where the uterosacral ligaments are. These are ligaments that hold the cervix up. And when you do laparoscopy, very often you find these endometriosis implants there. And all of these implants, they each have a nerve fiber. And that's why different patients have different symptoms. Some have painful sex. Some you find these implants on their bladder, so they present with bladder symptoms, with UTI symptoms. Mm-hmm. Some have it on the bowel, or they have bowel adhesions, so they have a lot of pain when they have a bowel movement. Other patients get these stabbing, shooting pains down their legs, and that's why it depends on where these implants are, these endometriosis tissues outside of the uterus, and which area of the body they're affecting.
Okay, and so I always like talking about these cells as these little. If you ever watch the movie Alien, and then
that's what they are.
Alien becomes itself, and then it starts to eat the tissues, but it has its own fibers,
supply.
blood supply, and each
estrogen.
one of these is this. It's so crazy when you think about it. Okay,
So what happens, I want to tell you that this chronic inflammation, because now you have these implants that's causing local inflammation, eventually they cause inflammation in the pelvis, and eventually this inflammation starts affecting the intestines. The intestines are right there in the pelvis. Right. So when you ignore this endometriosis, when you ignore this chronic inflammatory process that's happening in the pelvis, next thing you know, the bowel gets affected.
Do they just jump over there?
They don't just jump over there. They cause an inflammatory process. So when you think of endometriosis is an estrogen dominant, progesterone resistant, highly inflammatory condition. So the combination of those three affect your bowel. The most important thing to realize is that 90% of patients with endometriosis, in my opinion, have some form of leaky gut, IBS, irritable bowel syndrome. And usually they end up in the GI or gastroenterologist office or their primary care office complaining of these of bloating. And, when you have leaky gut, you know what leaky gut is?
No.
So when you get this overgrowth of bacteria in the small intestine, what happens is you get these breaks in the walls of the small intestine. So harmful substances start getting absorbed that are not supposed to get absorbed. And as that happens, it causes an inflammation, an inflammatory process. These are patients who complain of bloating, even when they're not on their period, especially when they eat. They usually complain of fatigue. They complain of weight gain because this inflammation also makes their insulin resistant worse. They complain of brain fog. They complain of anxiety, depression. They just don't feel well. And that inflammation is so real for these patients. So now you have a patient who has this chronic pelvic pain that presents in different shape or form. They're chronically bloated. They're fatigued. Their central nervous system is rewired to perceive this pain as so exaggerated that they constantly have this chronic pain, which all of it together affects the limbic system and the prefrontal cortex in the brain. The limbic system is the emotional headquarters of the brain. All of our emotions come from our limbic system, which is the hypothalamus, the amygdala, and the hippocampus. You don't need to know the parts of it. But this limbic system is our emotional headquarters. For this limbic system to function correctly, you need normal levels of estrogen. You need progesterone because progesterone turns into allopregnanolone that binds the GABA receptors in the brain that calms the brain down, calms this emotional headquarters down. And you need low inflammation. You need low stress. So what happens with endometriosis patients, these implants are estrogen dominant, so they're secreting a lot of estrogen. So you have this irregular estrogen expression. You have progesterone resistance. You have a lot of inflammation. So these are patients who eventually start feeling anxious. They start feeling depressed. They have brain fog. They can't concentrate. They have memory. They can't remember things. And they get very irritable. They get sad. So when we talk about endometriosis, it's not just a pelvic pain issue or a fertility issue. It does affect every organ in the body. And this chronic inflammation that affects their brain health, I think is so important to address, right?
Well, they're in so much pain too.
They're in so much pain. They get dismissed. No one helps them. Their mental health goes, right? And this becomes a vicious cycle. And
so let's talk about that. So you finally get a diagnosis by either you diagnose yourself by listening to these kinds of podcasts, or you go to your doctor and you give them your symptoms. How do you treat endometriosis?
The gold standard treatment for endometriosis is to go in laparoscopically, which is minimally invasive, meaning we use 3 tiny little cameras. They're 5 millimeter, 1 inside the belly button and 2 on the sides around the bikini line. And basically, we resect these implants. Literally, you have to search for them, find them one by one, grab them, cut them, and pull them out. You do not want to ablate them or burn them. Why? Because if you burn them, you're just killing the superficial layer. You're not really removing the deep infiltrating tissue that's invading into whatever organ it's invading into. So it's very important to resect it. The problem is many, I would say majority of gynecologists are not trained to deal with advanced stages of endometriosis. When you do laparoscopy, first of all, these lesions are tiny. They're tiny, but they're deadly. So you have to find them and you cannot leave any of them behind. You want to look for them. The easy ones to look for are the ones that have this purplish color. They look like a dot or a nodule, but it's purple in color. So
is that the blood inside of it? Okay.
And if you go close to it with your camera and you really look everywhere, and I'm telling you, you have to look everywhere. You have to put a manipulator in the uterus so when you're in, you can lift the uterus up because the most common place they sit is right behind the uterus. On the uterosacral ligaments, you want to look there. You want to look behind the uterus. You want to look on the bladder. You want to look on the pelvic sidewalls where the ureters go. It's very important. Sometimes we have to dissect the ureters out and release the ureters because the endometriosis.
What's a ureter?
Ureter is a tube that drains your kidneys and brings the urine to the bladder. You can't have that get blocked. We see that with endometriosis patients in advanced stage. One ureter gets blocked and their kidney starts accumulating urine and their presenting symptom is flank pain. So you don't want to get to that point. So whenever I see a lesion on the ureter, you literally have to grab it. You have to be very careful because you don't want to cut the ureter.
Right.
So it's a very, very technical surgery. You want someone who's done it. I don't know. I think you have to do at least 100 of them to get really good at it. The problem is a lot of patients, almost, I would say 80% of the patients that I do resection on, they also have stromal endometriosis. Now, stromal endometriosis, unless you know exactly what it looks like, you're going to miss it. Stromal endometriosis is from the connective tissue around that endometrial tissue. So it doesn't have the gland, so it doesn't have the purple blood in it. But these look almost, the way I can describe it, they look like white, clear, superficial ulcers.
Are they big?
Tiny.
They're tiny.
So unless you go close, sometimes I look at first glance, I'm like, oh, she didn't have it. And then I start looking, I'm like, there it is. And I get so excited.
And just one can cause massive pain.
So usually it's rare to just have one.
Right.
You just have to look for them.
Okay.
But that's why if you put a camera and you're looking for purple lesions and you just look around, you're going to wake that patient up and say you didn't have it. But these are so fine and they're so little, but they are more painful, more inflammatory, and less or more resistant to progesterone. So those are the ones you really have to remove because those cause a lot of inflammation and pain. But unfortunately, I would really tell you that 95% of doctors will miss it. So that's the problem. And that's why patients say, they come to my office crying. They're like, but I had laparoscopy last year and they told me I didn't have endometriosis. Meanwhile, this is a patient who passes out with her periods and ends up in the emergency room. I don't even need to do laparoscopy to diagnose her. So that's how they get missed.
And so let's say that you go in there, you get rid of all of these. We've talked about this. If you don't deal with the progesterone, then...
So when you think of endometriosis, the problem is, so now we know that finding a laparoscopic surgeon is not easy, who's an expert in endometriosis. And 50% of counties in this country don't have an OBGYN. So let's start there. 50% have no OBGYN. If you have a patient who you suspect endometriosis, you want to treat. Endometriosis implants, we learned, are estrogen dominant, progesterone resistant. However, the easier way to think about it is they grow with estrogen and their growth can be suppressed with progesterone. So what do you want to do? You either have to give it progesterone or pull the estrogen away. Right? How do we give it progesterone? There are different forms of birth control with progestins in it. You have the progestin IUDs, like Mirena IUD, Kylena IUD, Skyla, Liletta. These are progestin IUDs that you insert inside the uterus. They can last from 3 to 8 years, and they can help significantly with pain in many, many of patients with endometriosis. You can go to birth control pill. low-dose birth control pills. I like progestin-only birth control pills. I love using SHEMD birth control. It's a progestin birth control that can help these patients. The problem is a lot of these endometriosis patients, for reasons we discussed, already have anxiety, depression, brain fog. They just, their mood is not good. They don't feel well. So usually they don't do really well with birth control pills. That's why my first line in my practice is a progestin IUD. And if they haven't had kids, I love using the Kyleena IUD. It's a small IUD. It doesn't cause a lot of cramps. For patients who've had children, I go to Mirena. For patients who I do laparoscopy and they have extensive disease, advanced disease, then I might go to a higher dose progestin IUD like a Mirena IUD that I can leave in there for 8 years or until the patient's ready to have children. So so I would say, if you're listening to this podcast, you have painful periods, you don't even need to explain yourself or get a validation from your doctor. Go ask for a progestin birth control. Go ask for a Kyleena Mirena IUD. You can say, I want it for birth control. You don't need to explain yourself. Just put it in and give it 3 to 4 months. If it's not better, then you absolutely need to consider either laparoscopic surgery, or you can go to medications. We call them GnRH antagonists. Basically, these are a group of medications that will lower the estrogen production from the ovaries. Remember, I told you either give it progesterone or you pull estrogen away. These medications pull the estrogen away. And by doing that, they really calm down the endometriosis implants and the pain. There are 2 medications that I use. One is Oralissa and the other one is Myfembry. The problem is these medications can cause hot flashes or night sweats, some nausea maybe. Patients sometimes might get a little moody, but it has a very short half-life. It's a pill that you can take it daily. You can take it up to 2 years, because after 2 years, the bone loss that you might get from using these medications might not be reversible after 2 years, but up to 2 years, you're absolutely safe using it. I use these medications for my patients with advanced disease, but I want to make sure that they have a good ovarian reserve before I put them on this. As you know, and you've learned, endometriosis does affect your egg count and quality. So I always check an AMH, and I do, which is anti-Mullerian hormone, which is a test for ovarian reserve. It is not a test for fertility. A low AMH does not mean you're not going to be able to have children, but a low AMH is a telltale sign that the ovarian reserve is low, that you need to act on it. So if you can afford it, I would say you need to freeze eggs. But for patients who have a very low ovarian reserve, or on ultrasound, on transvaginal ultrasound, there's not that many follicles in their ovaries, I usually recommend egg freezing if they can afford it. And then I go to suppression with these medications like Oralissa or Myfembry.
So a teenager that has, debilitating, painful periods.
Birth control pill.
You do that first. That's the first. And same thing for anyone, that you always start with that first.
If someone's sexually active, I offer them a progestin IUD. Okay. But for young girls who are not sexually active, you can't put an IUD in. I go to birth controls like SHEMD.
Okay. And then from that point, you would decide whether to, if that doesn't work, whether to operate or whether to use those medicines. You wouldn't use those medicines on a young girl.
No,
okay.
18 and above.
Okay, great. So now you've gone in, you've done the surgery, you've taken them out, all that's good. You close them up beautifully.
And I put a progesterone IUD in them. I
That was my
convinced
question.
them
Okay.
to let me do it, because if you operate and don't suppress, your
comes right
patient bounces back. 6 months to 2 years, they're back. But if you, my personal experience in the past 25 years has been that if you operate, if you resect the way I resect, like cut every single one of those implants out that you can visually see, you can't see all of them, right? Some patients have microscopic disease that you can't see. But the ones you see that you do a good resection and you suppress them with a progestin IUD, the success rate is really, really high. Now, if I have a patient that during laparoscopy, I'm diagnosing them with stage 3-4 endometriosis and they have very extensive disease, for those patients, or if I have patients who have lesions by the diaphragm, or it involves their bowel, or it involves their bladder or their ureters, Then, in addition to surgery, in addition to a progestin IUD, I always add the Orilissa or Myfembry. And I do that for up to 2 years with them just to kill whatever's left behind. Now, but if they have low egg reserve after surgery and IUD placement, I send them for egg freezing. And then when they come back from their egg freezing, then I start them on either Myfembry or Orilissa. So for anyone listening, as long as you understand how these implants behave, now you understand that you want to try to give a progesterone, even though they tend to be progesterone resistant, especially the stromal endometriosis implants. You still want to give a progestin
with birth control or an IUD.
IUD or birth control. And if that doesn't work, you want to pull the estrogen away. Okay. But before you pull the estrogen away, make sure you have a normal egg count. I do that even before I start any treatment because you want to know what the reserve is. The AMH does not predict fertility, but it's a good predictor of your ovarian reserve. And if that reserve is low, you want to freeze earlier than later. If you have a couple that are, for example, trying to get pregnant at age 35 and you're now diagnosing the wife at age 29 with endometriosis, you want to have a conversation with them saying maybe it's not a good idea to wait till 35. Then let me do laparoscopy. Let me put a progestin IUD. And, you know, if you have advanced disease, I will treat it with Orilissa or Myfembry, but maybe we should consider embryo freezing. Or maybe you should consider trying for pregnancy at 31 or 32 instead of 35. So it just gives you this advantage of being able to have that conversation, especially for couples who desire future fertility. So they're not showing up at 35 with no egg reserve, completely shocked. And don't think this doesn't happen. It happens at least once a day in my practice. Women in their mid-30s, for the first time hearing about endometriosis, getting diagnosed with endometriosis, and they have the egg count of a 45-year-old, meaning they have like 2 follicles.
And you've told me before that you've had some young teenagers come into your office with severe
absolutely.
endometriosis whose eggs are...
I've had 16-year-olds that I've done egg freezing on. And, you know, it's because it's hard to predict how this disease progresses. When you have a 16-year-old with advanced endometriosis who's not responding to hormonal suppression and who has a low reserve, now, it doesn't mean that that teenager won't get pregnant, but I want to make sure she gets pregnant and I don't want to gamble with it. So if she has a low reserve, I will have a conversation about, egg freezing. And that's a conversation usually I have with the mom, or the parents or the dad, and before discussing it with the teenager. And, there's some moms who say, no, absolutely, I want to be proactive and I want to do this egg freezing. If I can stabilize it and I can suppress it, then I usually push it to 18. I want them to be a little bit more mature. But sometimes I have, 16-year-olds who have an ovarian reserve of a 40-year-old. So I don't want to risk waiting 2 more years.
And when I was trying to get pregnant way back in the day, we talked about endometriosis and how you would go in, this is before I knew you and knew what was happening in there, and they would scrape it all out, and then the next month you'd get pregnant because you cleaned it out. That's how it was kind of described. But why is it that it's so much easier? Is it because you've taken the inflammation out?
Bravo.
Okay, great. That's my question.
Bravo.
So
plus, we flush the tubes.
Right.
If the tubes are blocked, we address that. We assess the tubes. I assess the cavity. There's a sister diagnosis to endometriosis, which is called adenomyosis, which we see it in 50% of endometriosis patients. And that's when the walls of the uterus have cells similar to the endometrial lining in the walls of the uterus, and they become very inflammatory and and they can cause heavy periods and painful periods. So which we call it adenomyosis, and adenomyosis alone can increase your risk of miscarriage. Endometriosis, that inflammation, that toxic environment, that estrogen dominance, all of that affects your implantation. It affects your egg reserve. Patients who have endometriomas, which means the chocolate cyst, which means when you have these endometrial tissues inside the ovary, and every month it bleeds inside the ovary, and this chocolate cyst gets bigger and bigger, it destroys the egg count in the ovaries and the egg qualities. those patients, you have to be extremely careful, especially when you do laparoscopic surgery. If I can freeze their eggs, I would freeze their eggs and then take them to surgery.
Right.
Because once you start digging into the ovary, as careful as I am, I never try to zap or burn anything on the ovary. I literally cut the serosa of the ovary open. I grab the cyst, I peel it off. It can be very sticky and messy, and you get this bloody chocolate colored fluid that comes out. But you want to peel it all out, but you don't want to start burning everything if you have any bleeders, because as you burn their ovarian reserve.
Oh my God. And the same treatment is for all those different forms. You said the sister
Adenomyosis. So same thing. You can do systemic. I like to do progestin IUDs for adenomyosis.
And then now, can we talk about the stages? So we've talked about teenagers, we've talked about pregnancy. Now, perimenopause and menopause. When you start losing your estrogen, does your endometriosis get better?
So after menopause, yes. So because the ovaries stop secreting estrogen, a lot of the symptoms diminish after menopause. The pain gets better. However, for patients who've been dismissed for many years, if they have adhesions, if they have scar tissue, if they have the leaky gut, all of that still stays because it hasn't been addressed. But as women go through menopause and their estrogen drop, their symptoms improve. However, what happens in perimenopause and menopause? Patients start complaining of brain fog, hot flashes, night sweat, anxiety, depression, hair loss, skin thinning, and lack of sleep, and all these other symptoms. So what do doctors do? They start them on hormone replacement. So it's very, very important to recognize something, that hormone replacement, the estradiol in the patch form, the cream form, oral form, all of it can still stimulate these endometriosis tissues that are outside of the uterus, even after menopause. So it's very important for endometriosis patients, even the ones who don't have their uterus. Let's say you have a woman who had a hysterectomy for fibroid at age 40 and removed her uterus and tubes, but she still has her ovaries. After menopause, usually the doctors would tell her, you don't need progestin anymore, or we don't need to give you any progesterone because you don't have a uterus. We give progesterone and hormone replacement partly to block the effects of unopposed estrogen on uterine lining that can cause uterine cancer. Even though we give progesterone, macronized progesterone for sleep and for
which I love it. I love my progesterone
it's
for
a
sleep.
huge thing. However, a lot of doctors to this day still tell patients, you don't have a uterus, you don't need progesterone. I don't believe that's true. What I do for my patients who have history of painful periods, who've had a hysterectomy because of endometriosis, or give you a history of endometriosis, even if they don't have a uterus, I always give them the progesterone because I don't want to stimulate those endometriosis implants with these exogenous estrogen. The one other thing I want to add is patients with breast cancer who go on tamoxifen. Okay. I had a patient recently in my office, and I don't think doctors pay attention to this, and I don't think patients know about this. Tamoxifen is an estrogen blocker in our breasts and other parts of the body. However, it stimulates the endometrial lining inside the uterus. So it has the opposite effect inside the uterus. Remember, endometriosis tissue is a tissue similar to the uterine lining. So I have a patient who had breast cancer, and they've completely suppressed her estrogen, and they have her on tamoxifen. However, after 5 years of tamoxifen, she came to my office as a new patient complaining of a lot of pain in her pelvis. And when I did an ultrasound, she had endometriomas. And she was surprised because she's like, well, my estrogen is suppressed. However, tamoxifen can stimulate endometriosis.
Wow. Okay.
And most people don't know that. So for patients with history of endometriosis, it's important for them to share this information with their doctor if they have breast cancer and they need to go on tamoxifen. Someone needs to watch them.
Okay. Because you think, I'm done. I'm finished.
I'm
no longer
treating
having
my breast
children.
cancer.
Yes, everything. Well, we had some questions from our listeners. A lot of them, actually. This is probably the biggest episode with questions. Number one question, you've already answered it, but let's just rapid fire this. What are the main symptoms of endometriosis?
The most common symptoms of endometriosis are around pain, painful period, bladder symptoms, painful urination, painful sex with deep penetration, painful bowel movement, back pain, chronic pelvic pain, bloating. So it's all around pelvic discomfort that is related to your menstrual cycle. However, eventually it can become chronic and throughout the month.
Okay, can you have endometriosis without heavy periods?
Yes, absolutely.
Okay. Why do I have pain outside of my cycle?
So what happens with endometriosis, these implants at first, they give you pain a couple of days before your period, and then a couple of days before and a couple of days after your period, then 3 days before and 3 days after, then 4 days before. And eventually, as the inflammation goes up, as these implants start invading the tissue around them and cause scarring, they can cause a chronic pelvic pain that just doesn't go away. And remember that brain rewiring and central sensitization basically rewires your brain to constantly perceive pain in your pelvis.
Can endometriosis cause IBS-like symptoms?
Absolutely. And a lot of patients do have IBS, or they get diagnosed with IBS. The problem is, or SIBO, small intestinal bacterial overgrowth. Unfortunately, you can't treat the symptoms unless you address the underlying condition, which is endometriosis.
Why does it hurt when I pee or poop?
You might have endometriosis implants on your rectum. You can have adhesions of your bowel. And most commonly with bladder, I see endometriosis implants on the bladder. And it's so important to grab those, even though they're sitting right on the bladder. But it's still, I would say it's easy for me, but I grab it and I superficially resect it without damaging the wall of the bladder. But they need to be resected.
Can endometriosis spread?
Spread as form of cancer, no, but it progresses every month.
So someone listening that knows they have endometriosis, what are the criteria they should be looking for a surgeon that will help their endometriosis?
I would say probably Google endometriosis surgeon near me. Research. There's always, if you have to travel. The last thing you want to do is have surgery with someone who hasn't done it and they wake you up and they tell you didn't have it, because then you're going to waste a lot of time and you've put yourself through surgery. So if you have to travel, I would say travel. If you have to drive an hour, drive an hour. If you have to fly 2 hours, then fly 2 hours. And find an endometriosis specialist. These are gynecologists who are minimally invasive surgery trained, and they're very good laparoscopic surgeons, and they routinely operate on endometriosis and endometriosis alone.
Okay, great. So you can say that. How many surgeries have you done of endometriosis?
Do you do this commonly? Do you resect them? How many have you done in the past month?
Right.
Do you do one a year, or are you doing 7 of them a week?
Okay.
So it makes a difference.
And our final question, which we've talked about this, but why didn't my ultrasound show anything?
These implants are in millimeters. Some of them are 5 millimeters, 3 millimeters, 2 millimeters. You know the metric system, how tiny these lesions are. So some of them are deep infiltrating. Some of them are tiny. Some of them are superficial ulcerated. They're so tiny that you cannot possibly see it on ultrasound. There are several ways of looking for endometriosis on ultrasound. One, if I see tons of adenomyosis in a young woman, remember the sister diagnosis is adenomyosis, so that's a telltale sign sometimes that you don't want to dismiss. Second, I see a lot of pelvic free fluid that I see a lot with endometriosis patients. Number 3, these are patients who have endometriomas or chocolate cysts. You don't have to have a big chocolate cyst. It's a specific look on ultrasound. You cannot miss it. The size doesn't matter. The presence of it matters. As soon as I see endometriomas on ovary on ultrasound, then I know my diagnosis. And the last thing I look for are in advanced stages when you have a lot of adhesions. One thing we see on ultrasound is what I call kissing ovaries. So ovaries are free floating and usually they're to the side of the uterus. As endometriosis advances and you have a lot of inflammation and scar tissue develops, sometimes you see these ovaries come behind the uterus and they touch. So if you see posterior to the uterus 2 ovaries touching, that's your diagnosis.
Wow.
You better go in there and look.
Okay. Amazing. I think I just want to leave our viewers and listeners with just what you told me. when I first met you on that first day that we met each other, which is painful periods are not normal.
No.
Painful periods are not normal. And if you're getting dismissed, just keep trying and advocating for yourself. Listen to another podcast we did, which was Olivia Culpa. It was an amazing podcast. And she's had every single one of these endometriosis symptoms in terms of her bowel,
And she got dismissed for years.
For years.
Palsy got dismissed for years.
And these are
So
women
many,
who obviously have access to the most amazing healthcare. So hopefully today's episode of Ask Dr. A is helpful, and just keep sending us questions, anything you want to know about anything in women's health. But we're going to be doing these Ask Dr. A episodes quite a bit where we deep dive into specific women's health topics. So send us ones that you need answers with. And we just really appreciate you, and thank you for listening and watching SHEMD. Thanks so much for joining us today on SHEMD.
If you want to own your own health, a good place to start is by following us on social media at SHEMD Podcast and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SHEMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SHEMD, some of the products and services we discuss may involve sponsorships or paid advertising.